Yes, ma'am. So here only you will be available.
Okay.
So the questions I'll be taking from the delegates link to the speaker link later.
Okay. Okay.
So, ma'am, shall we start?
Yeah, yeah.
Okay, thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request everyone to please comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Aliya Reddy, who is a clinical head at ART Fertility Clinic, Hyderabad. She is also a medical director in Medicover Fertility Center, Hyderabad, and she done her diploma in endoscopy from KL School of Germany, and also she have done her fellowship in ART from Asuta Medical Center, Israel. And also she is a member of ISHRE, ICER, IFFS, and FOXY with 35 years of experience in 20 years in gynec and ops, as well as 15 years in infertility. Coming to awards, she is a recipient of Myla Award from Telugu Desam in 1999 and also Dr. B.C. Roy Award for the Best Doctor in 2019. And also she has an experience of giving live shows in many TV channels. So with this, we welcome you for today's webinar, ma'am. And as you know that this webinar is streamed to the Shieldconnect. If you miss any part of the program, it will be available in the Shieldconnect webpage as well as Shieldconnect YouTube page. And coming to the today's topic, as we know that endometriosis is the most common cause of chronic pelvic pain in women. It affects women both physically and psychologically. And till date, there is no definitive cure for it. So with this, without wasting much time, let me turn over the time to Dr. Aliya Reddy ma'am to talk on current trends in endometriosis. Over to you, ma'am.
Good evening, everyone. It's a pleasure speaking to you again, but I feel bad being in a virtual platform, waiting for a physical way we can see each other and say hi to each other. Still, I think we'll be doing it very shortly. But now coming to my topic, that is current trends in endometriosis. We must have all heard. It has become a common term these days. Like we must have all heard. We have seen people suffering. We have treated them, and so let's know what is endometriosis and what are the latest trends, current trends for the treatment. Okay. So to start with, yeah. So what is endometriosis? It's an agonizing condition where a major health problem in women during the reproductive age is a chronic and recurrent disease. It is defined as the presence of functional endometrial, glandular, or stroma cells outside the uterine cavity. The lesions can be peritoneal lesions, superficial implants, or cyst on the ovaries, or deep infiltrating disease. So prevalence of endometriosis. Now, globally, endometriosis is known to affect about 10% of women of reproductive age, which translates to approximately 176 million women. According to the Endometriosis Society of India, the number of women with endometriosis is estimated to be about 25 million. The high prevalence rate, both globally and nationally, indicates the alarming situation and needs to draw attention from both researchers as well as physicians. So pathogenic theories of endometriosis. The definite pathogenesis of endometriosis is still unknown, but there are a number of leading theories, including retrograde menstruation, coelomic metaplasia, altered immunity, stem cells, and genetics. The most predominant theory is of retrograde menstruation. It is proposed that with retrograde menstruation, the endometrial glands and stroma are attached and implanted in the peritoneal cavity. So retrograde menstruation, the definite, so the most well-accepted theory, retrograde menstruation, states that endometrial tissue is transported in a retrograde fashion through the patent fallopian tubes into the peritoneal cavity. The endometrial cells then attach to the peritoneal mesothelial cells, establish blood supply, proliferate and produce endometrial implants. Women with endometriosis have higher volumes of refluxed menstrual blood and endometrial tissue fragments than women without the disorder. However, the incidence of retrograde menstruation is similar in women with or without endometriosis. So the pathogenesis appear to be multifactorial mechanism. So signs and symptoms of endometriosis. The clinical presentation of endometriosis varies. Although 20 to 25% of the patients of endometriosis are asymptomatic, typically endometriosis causes pain and infertility. Patients often present with symptoms such as intramenstrual bleeding, painful periods, painful intercourse, painful defecation, and painful urination. Hemoptysis and infertility in association with one or two of the above said reasons. Pelvic pain may present before menstruation begins. Other symptoms indicate of endometriosis include pain and heavy feeling in the lumbosacral column or legs, nausea, lethargy, chronic fatigue, any cyclic pain affecting other organs, hemoptysis, scapular or thoracic pain, and acute abdomen. Risk factors of endometriosis. The factors increasing the risk of endometriosis include increasing age, early menarche, shorter menstrual cycle interval, prolonged menstrual flow, family history of endometriosis, low body weight, intercourse during menses, and caffeine intake. So comorbidities associated with endometriosis. Patients with endometriosis may be at high risk of developing several other chronic diseases. A study including 227 women with infertility showed that the prevalence of adenomyosis was reported as high as 79% among women with surgically confirmed endometriosis, compared with 28% among women without endometriosis. Cancer is one thing, where endometriosis is known to be positively associated with cancer, example, endometrioid ovarian cancer. And then the autoimmune disease, patients with endometriosis show a high risk of autoimmune disease such as SLE, Sjogren syndrome, multiple sclerosis, and rheumatoid arthritis. Then coming to see cardiovascular conditions, patients with endometriosis are at a greater risk of myocardial infarction, angina, need for coronary artery bypass, graft surgery, coronary angioplasty, or stent placement. Other cardiovascular disease risks such as hypertension and hypercholesteremia are also associated with endometriosis. Endometriosis has a negative impact on the quality of life. The painful symptoms may significantly impair physical, mental, and social well-being, and infertility itself may cause psychological stress, low self-esteem, and depression. Improvement of quality of life should be considered an important point during the management of endometriosis. Now, how do you diagnose endometriosis? The preliminary diagnosis of endometriosis is usually based on the clinical history, as a majority of women show normal results on physical examination. The clinicians palpate for uterine or adnexal tenderness, a retroverted fixature, nodulating uterosacral ligament, and any pelvic mass. A tenderness on palpation of posterior fornix is the most common finding. Differential diagnosis is important because pelvic pain is also a symptom of other diseases, such as pelvic adhesions, adenomyosis, gastrointestinal or urological disorder. Other causes of pelvic pain should be ruled out by carrying out appropriate diagnostic tests like urine analysis, pap smear, pregnancy test, vaginal and endocervical swabs. Pelvic masses are visualized by the use of transvaginal and transabdominal ultrasound. Occasionally, an MRI and CT scan are conducted to characterize the pelvic masses. Laparoscopic inspection with histological confirmation after biopsy is a gold standard for diagnosis. Need of early diagnosis of endometriosis. The average delay in diagnosis of endometriosis is about 6 to 7 years, resulting in unnecessary suffering and reduced quality of life. Sorry. As a majority of women with endometriosis report the onset of symptoms during adolescence, early referral, diagnosis, identification of disease, and treatment may mitigate pain, prevent disease progression, and thus preserve fertility. Barriers to early diagnosis include high cost of diagnosis and treatment in adolescent patients and presentation of confounding symptoms such as cyclic and acyclic pain. Thus, a non-invasive tool to diagnose endometriosis could facilitate early diagnosis and intervention that could ultimately improve quality of life and preserve fertility. Grading and classification of endometriosis. American ASRM classification system is the most widely used classification worldwide. It considers the intraoperative disease findings and takes into account peritoneal endometriosis, ovarian endometriosis, posterior cul-de-sac obliteration, ovarian adhesions, and tubal adhesions. Scores are assigned to endometriosis lesion in the peritoneum and ovaries using points that correspond to the size of the lesion. By analogy, points are also assigned for adhesions on the ovaries and fallopian tube. Additional points are assigned for partial or complete posterior cul-de-sac obliteration. The assigned points are summed up and a value is obtained to classify the disease based on its severity. Stage 1, minimal 1 to 5 points, usually comprise few superficial endometriotic spots or adhesions. Stage 2, mid 6 to 15 points, can be few deep peritoneal lesion solely or in combination with superficial lesions and flimsy adhesions. Stage 3, moderate 16 to 40 points, often include an endometrioma by itself or in combination with superficial or deep endometriosis or dense adhesions. Stage 4, severe, more than 40 points, is often characterized by all of the above, as well as the bilateral ovarian endometrioma or dense adhesions that can lead to a partial, a complete obliteration of a lesser or true pelvis. Grading and classification of endometriosis. The Enzian classification was developed as a supplement to the ASRM classification score in order to provide a morphologically descriptive classification of deep infiltrating endometriosis, taking into account retroperitoneal structures. The prefix F stands for far or foreign, referring to a distant retroperitoneal structure. The Enzian classification nomenclature is similar to the tumor, lymph nodes, metastasis staging system used in the cancer staging. So now coming to the most important thing is that is endometriosis and infertility, because 10 in every 10 patients we see at least 4 to 5 patients of endometriosis. So this endometriosis definitely affects the fertility. So now knowing that it is closely linked with infertility, in normal couples, fecundity is in the range of 0.15 to 0.2 per month and decrease with age. Women with endometriosis tend to have a lower monthly fecundity of about 0.02 to 0.1 per month. Also, endometriosis is associated with lower live birth rate. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. Chronic inflammation at the core of endometriosis. Now, women with endometriosis have immunologically dysfunction preventing the removal of endometrial implants and leading to tissue adhesions in the peritoneal cavity. These peritoneal endometrial lesions are responsible for the activation of macrophages and with consequent increase in the generation of inflammatory factors, reactive oxygen and nitrogen species, pro-inflammatory cytokines such as interleukin-1 and IL-6, and tumor necrosis factor, growth factor, and prostaglandins in the endometrial lesions. A marked inflammatory response with exacerbation of reactive species and cytokines makes the pelvic environment adverse, that is reflected in the peritoneal fluid. These alterations may lead to chronic inflammation, proliferation of the lesions, local hormonal imbalance, resulting in poor oocyte quality, poor sperm motility, embryotoxicity, and reduced endometrial receptivity. Increased production of prostaglandin along with chronic inflammation leads to pain. So pathogenic mechanism in endometriosis associated with infertility. The pathogenic is associated in endometriosis include underlying adhesions, ovarian cyst, changes in the tubal anatomy, abnormal folliculogenesis, elevated oxidative stress, altered immune function, altered hormonal milia, the follicular and peritoneal environment, and reduced endometrial receptivity. Role of inflammation in endometriosis associated with infertility. The immune function is known to be dysregulated in endometriosis patients. Peritoneal endometrial lesions are responsible for the activation of macrophages with consequent increase in the generation of inflammatory factors, reactive oxygen and nitrogen species, cytokines, growth factors, and prostaglandin. This makes the pelvic environment adverse, which is reflected in the peritoneal fluid of this woman. These changes in the microenvironment cause oocyte damage, one second. The pathogenic mechanism in endometriosis associated fertility. The major pelvic adhesions. So endometriosis finally with all the immune system decrease results in major pelvic adhesions, including those that result from endometriosis, can impair oocyte release from the ovary or inhibit ovum capture or transport. Altered hormonal and cell-mediated functions. IgG and IgA antibodies and lymphocytes may be increased in the endometrium of women with endometriosis. These abnormalities may alter endometrial receptivity and embryo implantation. Auto antibodies to endometrial antigens are reported to be increased in some women with endometriosis. Endocrine and ovulatory abnormalities. It has been proposed that women with endometriosis may have endocrine and ovulatory disorders, including luteinized unruptured follicular syndrome, luteal phase dysfunction, abnormal follicular growth, and premature as well as multiple luteinizing hormone surges. There is some evidence to suggest that endometriosis may be associated with a long follicular phase with possible low serum estradiol level and low LH-dependent progesterone secretion during the luteal phase of the cycle. Impaired implantation. Some evidences suggest that disorders of endometrial functions may contribute to the decreased fecundity observed in women with endometriosis. Reduced endometrial expression of AVB3 and integrin, a cell adhesive molecule, during the time of implantation has been described in some women with endometriosis, but this finding has not been replicated. Impaired progesterone signaling exacerbates endometriosis symptoms. In endometriosis, when endometrial tissue grows outside the uterine cavity, progesterone and estrogen signaling are disrupted, commonly resulting in progesterone resistance and estrogen dominance. Progesterone resistance describes a suppressed cellular response to progesterone exposure. This hormone imbalance leads to heightened inflammation, may also increase pelvic pain and decrease endometrial receptivity to the embryo implantation. In endometriosis, it confers endometrial tissue the ability to remain viable at foreign location through successive menstrual cycle, as attention of progesterone targeted genes allows for continued growth and cell survival. Which therapy should be preferred for early endometriosis? Medical treatment for endometriosis should prevent loss of reproductive health and enhance quality of life. Endometriosis treatment goals should include relieve or reduce pain symptoms, shrink or slow endometrial growth, preserve ovarian reserve and restore fertility in a long time use, prevent and delay the recurrence of the disease. Recommended hormonal therapy for endometriosis. Currently, progesterones and antiprogesterones, non-steroidal anti-inflammatory drugs, analgesics, combined OC pill, GnRH agonist and antagonist, and aromatase inhibitors are in the clinical use. With no overwhelming evidence to support particular treatment over others, it is important that the decision involved in any treatment plan are individual, and that the woman is able to make this based on an informed choice and good understanding of what is happening to her body. Should focus on fertility preservation in women desiring conception. Family preservation, women of reproductive age 18-40 should be the focus of endometriosis therapy. Women with endometriosis are at risk of decreased ovarian reserve and ovarian tissue damage that can lead to infertility, reduced response to ovarian stimulation, and premature ovarian failure. Although many drugs are available for endometriosis treatment, there is an unmet need for a therapy that can preserve fertility while mitigating the endometriosis-associated pain. New oral medication and clinical trials are there. In summer of 2018, FDA approved the first oral gonadotropin releasing hormone GnRH antagonist called elagolix to help with moderate to severe pain from endometriosis. Elagolix is a daily pill. It works by stopping the production of estrogen. The hormone estrogen contributes to the growth of endometrial scarring and uncomfortable symptoms. Two more oral GnRH antagonists, linzolix and regulox, are currently being studied in clinical trials for treating endometriosis pain. Another clinical trial is underway to assess the use of DCA or for treating endometriosis. DCA is currently used to treat metabolic disorders in children. Preliminary data shows that DCA could help stop the growth and survival of the endometriosis cell and reduce lactate production in the pelvis, which women with endometriosis are thought to have more of compared to women without endometriosis. And the latest also being the cannabis for endometriosis. In 2020 study found that 59% of women who reported using cannabis for endometriosis relief was able to stop relying on pain medication, including opioids. This may be related to increasing evidence that cannabis or cannabinoids help restore imbalance in the endocannabinoid system that are thought to contribute to the endometriosis symptoms. And pelvic floor physical therapy. Pelvic floor physical therapy is increasing in popularity among those with endometriosis. Research from a 2021 study found that regular pelvic floor physical therapy can help reduce endometriosis symptoms like a painful sex and pelvic pain and improve pelvic relaxation in women with this condition. There's another way of pseudo-pregnancy. Ovulation and menstruation are inhibited for 9 months using a combined OC pill or a progesterone alone to avoid the estrogenic side effects. A combined contraceptive tablet is given daily. Oral Provida tablets is given the dose of 10 to 30 mg daily. Side effects of progesterone are headache, weight gain, fluid retention, breakthrough bleeding, and depression. So pseudo-pregnancy has its own side effects. Androgenic effects include acne, male alopecia, hirsutism, hoarseness of the voice, and hypertrophy of the clitoris. Hypoestrogenic effects include hot flushes, sweating, atrophy of the breast, atrophy vaginitis, dry vagina, dyspareunia, and decreased libido. Anabolic effects include weight gain and edema. Metabolic effects include impaired glucose tolerance, increased insulin requirements in diabetic cases, hepatic dysfunction, blood pressure may be elevated. CNS include headache, sleep disorder, anxiety, depression, and visual disturbance. GIT include nausea, vomiting, and constipation. Musculoskeletal muscle cramps and swellings of the joint and hematuria also are there as a side effects of pseudo-pregnancy. Now, second is pseudomenopause. A GnRH agonist is given. Naphthaliin intranasally used a nasal spray, 200 micrograms twice daily. Zoladex, 3.6 mg injected subcutaneously every 4 weeks. And decapeptyl, 3.75 mg injected IM every 4 weeks. Again, this also has a side effects like hot flushes, dryness of the vagina, dyspareunia, and reduced libido. So surgical treatment indication, when should we go for the surgical treatment includes larger lesions when hormonal therapy fails. Surgery is conservative or radical. Conservative surgery is in young patients below 40. Presacral neurectomy has been used to treat severe dysmenorrhea. Minimal to mild disease can be removed by laser or electrocautery. Surgery for treatment of endometriosis-associated fertility. In infertile women with AFS-ASRM stage 1 and 2 endometriosis, clinicians should perform operative laparoscopy, excision or ablation of the endometriotic lesion, including adenolysis, rather than performing diagnostic laparoscopy only to increase ongoing pregnancy rate. In infertile women with AFS-ASRM stage 1 and 2 endometriosis, clinicians may consider CO2 laser vaporization of endometriosis instead of mono, since laser vaporization is associated with higher cumulative spontaneous pregnancy rates. Surgery for the treatment of endometriosis-associated infertility. In women with minimal to mild endometriosis, the evidence summarized in the Cochrane review shows that operative laparoscopy is more effective than diagnostic laparoscopy in improving ongoing pregnancies. The comparative effectiveness of different surgical techniques is less well studied. In women with moderate to severe endometriosis, there is no control studies comparing reproductive outcome after surgery and after expectant management. The recommendations are based on the evidence from two high-quality prospective cohort studies showing crude spontaneous pregnancy rate of 57 to 69%, moderate endometriosis, and 52 to 68% in severe endometriosis after laparoscopy surgery, and on evidence from the one high-quality prospective cohort study showing much lower crude pregnancy rates from expected management of 33% moderate endometriosis and 0% in severe endometriosis. Surgery prior to treatment of ART in women with ovarian endometrioma. Laparoscopic ovarian cystectomy in women with unilateral endometrioma before ART may not be useful in improving cyclic outcome. This conclusion is drawn from several studies, but is weak because of limited consistency in the interpretation of the result based on no difference in the pregnancy rate. Some authors advise cystectomy, whereas others advise caution with surgery because of the possible harmful effects on the ovarian reserve. Adhesion prevention after surgery. The use of oxidized regenerated cellulose in prevention of adhesions formation after laparoscopic surgery for endometriosis can be effective. Although based on the systemic review, the evidence level was downgraded to, since the systemic review was based on a small number of studies, with limited numbers of patients per study, the effect of adhesion prevention on fertility or pain is uncertain. The use of icodextrin in prevention of adhesions formation after laparoscopy surgery for endometriosis is probably not effective. In the study of Brown and colleagues, a moderate benefit of icodextrin was described, but this applied to only a specific small subgroup of patients. A more recent trial did not show any benefit of this. Further, the studies was sponsored by the manufacturer. Hence, the GDG has decided not to recommend for adhesion prevention. Now, coming to the latest trends, reprogramming cells. In 2018 study from Northwest Medicine, researchers discovered that induced human pluripotent stem cells can be reprogrammed to transform into healthy replacement uterine cells. This means that uterine cells causing pain or inflammation can be replaced with the healthy cells. These cells are created from the person's own supply of iPS cells. This means there is no risk of organ rejection as there is with other types of transplant. More research is needed, but there's a potential of cell-based therapy to be a long-term solution for endometriosis. Next is gene therapy. Some researchers suggested that suppression of specific genes may play a part. Scientists of Yale University published study in 2018 that found that the microRNA LET7B, a genetic precursor that controls gene expression, is repressed in women with endometriosis. The solution administering LET7B may help treat the condition. This researchers saw big reduction in endometrial lesions after injecting mice with LET. More research is needed before testing in humans. DNA variation is a gene that produces protein neuropeptide S, receptor 1, occurs more often in women with endometriosis compared with those without the condition. NPSRI is thought to play a role in the endometriosis-related inflammation. The drug used in the study to shut down NPSRI activity was effective in mice, but is not approved for use in humans. More research is needed to develop a similar options for use in humans that may help treat endometriosis. If gene therapy does prove effective in humans, it could be a non-surgical, non-invasive, and non-hormonal way to treat endometriosis. Now, the key points of the endometriosis are endometriosis is a disease where tissue similar to the lining of uterus grows outside the uterus, causing pain and infertility. Endometriosis affects roughly 10% of the reproductive age women and girls globally. It's a chronic disease associated with severe life impacting pain during periods, sexual intercourse, bowel movement, and urination, chronic pelvic pain, abdominal bloating, nausea, fatigue, and sometimes depression, anxiety, and infertility. The variable and broad symptoms of endometriosis mean that health workers do not easily diagnose it, and many individuals suffering from it have limited awareness of this condition. This can cause a lengthy delay between the onset of symptoms and diagnosis. At present, there is a no known cure for endometriosis, and treatment is usually aimed at controlling symptoms. Access to early diagnosis and effective treatment of endometriosis is important, but is limited in many settings, including in low and middle income countries. There is a need for more research and awareness raising around the world to ensure effective prevention, early diagnosis, and improved management of the disease. Thank you.
Thank you very much, ma'am, for the wonderful presentation. We are very honored to have you, and we are honored to learn you, ma'am. Thank you very much, ma'am. Ma'am, if you allow me, then we can take the questions.
Yeah.
Thank you, ma'am. We have first question that is,
Yes.
it is said that there is no relation with endometriosis severity and symptoms. How disease severity can be predicted and given TT to decrease the progression of the disease?
I didn't. Can you come out once again?
Yeah, ma'am. How disease severity can be predicted and given the treatment to decrease the progression of the disease?
Yeah, sometimes it happens. We have seen cases where endometriosis is severe, but a patient presents with no symptoms. It depends on where the implants are, mainly where the implants are. If it is associated, even a smaller endometriosis will cause severe pain if it is on the root of a nerve. So we never know the severity unless, as I told you, we have to go for an MRI or a CT scan to really rule out the severity of the disease. And laparoscopy is a gold standard for it.
Thank you, ma'am. And ma'am, we have one more question that is, any role of medical management for scar endometriosis?
Medical management is, see, we have to treat individually according to the symptoms. It is only symptomatic. If you have a pain, you give analgesics. If you have anything, only thing, because in young women, we can't go very aggressive about the hormonal therapy because we'll be affecting their reproductive system. So accordingly, it has to be given symptomatic. What is the presentation? What is her symptom? And accordingly, the treatment.
Thank you very much, ma'am.
Yes.
Ma'am, we have one more question that is there any benefit of giving vitamin A in endometriosis?
See, we have learned that endometriosis is mainly the cause by retrograde menstruation from the fallopian tubes and implant. See, these are the endometriotic cells which gets implanted in the peritoneal cavity. So whenever there is a hormonal change, it is directly related to the hormonal changes. Whenever that girl has menstruations, these cells which are there outside the body gets activated, they start bleeding, thereby attracting the nearby organs for adhesions. So it is mainly hormonal. How far vitamin A affects, I have no idea. As it is a hormonal based disease.
Thank you, ma'am. Ma'am, there are no more questions from the delegates. If you allow me, then we can close this webinar. And if any more questions, we will definitely pass it on to you.
Right. Thank you.
Thank you very much, ma'am. And we are very honored to have you, ma'am. And we look forward for your continuous support for this education.
Thank you. Yeah,
thank you, ma'am. And I thank all the delegates for their active participation. Many thanks from the Shield team. Thank you, ma'am. Thank you all.
Thank you, ma'am.
Thank you, Sai.
Thank you, Saiti.